So I want you to picture this scenario. You're sitting in a doctor's office. You're, perched on that crinkly paper on the exam table.
Oh, yeah, we all know that terrible sound.
Right. And the fluorescent lights are just humming overhead, and you are facing a major medical decision.
Like a complex surgery or a new medication.
Exactly. Or, a family planning choice. But here's the catch. Your partner is sitting in the chair right next to you, and they have a very strong, very vocal opinion about what you should do.
Which happens a lot.
Right. They might be interrupting the doctor or rattling off statistics they read online. Or maybe they're just staring at you with that heavy, expectant look that you know all too well.
Yeah, the invisible pressure.
Exactly. So in that moment, who is the doctor actually listening to? Like, should your partner's opinion influence your treatment decisions? Does their voice carry any legal or ethical weight in that room?
Well, it's a dynamic that plays out in clinics every single hour of every single day, honestly. We tend to think of medical care as this sterile, purely scientific transaction between a patient and a physician.
Yeah, very black and white.
But the reality of the exam room is that it's incredibly crowded. You bring your own values and fears into that space, and you also bring the invisible and sometimes very visible pressures of the people sitting beside you.
And that tension right there is the whole mission of our deep dive today. We are exploring the boundaries of medical consent, shared decision-making, and all those quiet pressures that follow you into the clinic.
It's a heavy topic.
It is. We really want to figure out, how much bodily autonomy do we actually have, and who holds the power when we are at our most vulnerable?
And to get to the bottom of that, we're drawing on a pretty heavy stack of official medical and ethical guidelines.
The real official rule books.
Yeah, exactly. We'll be looking at frameworks from the National Institute for Health and Care Excellence, the British Medical Association, and eventually some really vital trauma-informed care guides on intimate partner violence.
But, before we get into how a partner might improperly influence a decision today, we first have to understand who legally holds the power to make that decision in the first place, right?
Right, because the patient wasn't always the one in charge.
Yeah, if we rewind a few decades, we lived very much in a doctor knows best kind of world. Paternalism was basically the entire foundation of medicine.
It wasn't just the culture, it was the explicit legal standard. For a really long time, medical consent in places like the UK was governed by something called the Bolam test.
The Bolam test.
Yeah. Under the Bolam test, a doctor's duty to warn you about the risks of a treatment was based almost entirely on what a, quote, responsible body of medical opinion thought was appropriate.
Wait, really?
Yeah. If a group of doctors collectively agreed that, say, a 1 in 100 chance of nerve damage just wasn't worth worrying you over, your doctor did not have to mention it to you.
Wait, so the medical community was essentially just policing itself?
Yeah.
Like they were deciding behind closed doors what information you were legally allowed to know about your own body?
It was a completely closed loop. I mean, the psychology behind it was this idea that patients were, too fragile to handle complex medical statistics.
Oh, wow.
Yeah, and that detailing every single risk would just scare them away from necessary treatments. But in practice, it mostly just protected doctors from liability.
I can imagine.
But that entire philosophy actually came crashing down with a landmark UK Supreme Court case in 2015. It was Montgomery versus Lanarkshire Health Board.
Okay, the Montgomery ruling. That is the one that completely flipped the script on who holds the power.
It really did. The court fundamentally dismantled that old Bolam test for consent. They ruled that patients must be informed of any material risks before undergoing a procedure. And here is the crucial shift. The definition of a material risk was no longer based on what doctors thought. It was based on what a reasonable person in the patient's position would attach significance to.
Okay, let me try to put this in a real-world context. It sounds kind of like buying a house.
Okay, how so?
Like under the old Bolam test, the home inspector only told you about a slightly leaky roof if a bunch of other home inspectors agreed it was a big deal.
Right.
But under the Montgomery ruling, the inspector is legally obligated to tell you about that leaky roof if they know you specifically have, like, a severe allergy to mold and absolutely hate water damage.
That analogy hits the nail on the head, actually.
The power to decide what matters shifted entirely to the individual.
Exactly. The Montgomery ruling legally recognized that you are the ultimate authority on your own life. And this brings us to a core concept that the National Institute for Health and Care Excellence, or NICE, outlines in their guidelines. Shared decision-making. The idea is that consent isn't just, handing you a clipboard with a dense legal form to sign in the waiting room.
Right, which is what it usually feels like.
Exactly. But shared decision-making is supposed to be a collaborative, joint process. Tests and treatments are chosen based on the clinical evidence, obviously, but they must be equally based on your individual preferences, beliefs, and values.
Okay, I understand the theory there. But how does that actually work in practice?
It can be tricky.
Right, because we've all been to a modern doctor's office. You get a 15-minute slot if you're lucky, the doctor hits you with a barrage of medical jargon, and you mostly just nod along because you feel rushed.
Yeah, it's overwhelming.
So how do they functionally ensure you are actually sharing the decision?
That is where specific communication techniques come into play. NICE guidelines actively train doctors to break that cycle of monologue. They use a method called chunk and check.
Chunk and check.
Yeah. Instead of delivering a 10-minute lecture on the side effects of a medication, the doctor breaks the information into small, digestible chunks. Then, they pause to check your understanding before moving on.
So they aren't just talking at you, they are forcing a dialogue.
And they pair it with something called teachback.
What's that?
A doctor might say, I've just shared a lot of information about how to take this new insulin. Just to make sure I explained it clearly, can you tell me how you're going to handle your dosage if you miss a meal?
Oh, that's clever.
Yeah.
It puts the onus on the doctor's teaching skills rather than the patient's listening skills.
Exactly.
Like, they aren't saying, did you understand me? Which makes people feel stupid. They are saying, did I do a good job explaining this?
It completely lowers the defenses of the patient while guaranteeing the communication is a two-way street. So, theoretically, the patient is firmly in the driver's seat.
Which brings us to the central question of this deep dive. The patient is in the driver's seat, but what happens when there is a passenger, like that opinionated partner we talked about at the beginning, trying to grab the steering wheel?
Yeah, that happens a lot.
Let's say I am sitting there, I'm fully awake and aware, but my partner is dominating the conversation. Can they legally give consent on my behalf?
The British Medical Association's ethics toolkit is completely unequivocal on this point. Family members do not have the legal authority to give or withhold consent on behalf of an adult patient who has capacity.
Hold on, I want to push back on that for a second. Isn't that a bit rigid?
How do you mean?
Well, if my partner and I share finances, if we are raising kids together, a massive medical decision, like a risky surgery or a treatment that puts me out of work for 6 months, heavily impacts them too.
It does.
So why shouldn't they get a legal say in what happens?
Because the law draws a hard boundary at your skin. Your partner's concerns about finances or childcare are entirely valid for a conversation at your kitchen table. But in the exam room, bodily autonomy supersedes all of that.
Wow, even if they're my spouse.
Even then, even if you have formally appointed someone as a health and welfare attorney, that legal power only activates if you physically or mentally lose the capacity to make decisions for yourself.
So if I'm awake, aware, and able to communicate, my partner's opinion means legally nothing.
Nothing at all. For your consent to a medical procedure to be legally valid, it has to stand on 4 incredibly specific pillars.
Yeah, what are they?
First, you must have capacity. Second, you must have received sufficient information. Third, you must be aware that you have the right to refuse the treatment entirely. And fourth, you must be acting voluntarily, entirely free from undue pressure.
Let's break those down because they sound simple on paper but incredibly messy in a 15-minute appointment.
They really are.
How does a doctor even measure capacity on the spot? Is it just an on and off switch?
It's more like a series of distinct locks. Capacity isn't a blanket trait, it is decision-specific.
Oh, interesting.
Yeah. A patient might have severe dementia and lack the capacity to consent to a complex open-heart surgery, but they might still possess the capacity to consent to a simple blood draw.
So it changes based on the context.
Exactly. The doctor has to evaluate if you understand the specific information relevant to the specific decision in front of you at that exact moment.
That makes sense. And the second pillar, sufficient information, ties right back to the Montgomery ruling. They have to tell you the risks that matter to you.
Right.
But what about that third pillar? The right to refuse. Why is that even a pillar? I think we all generally know we don't have to take a pill if we don't want to.
You'd be surprised, honestly. The medical environment carries massive inherent authority. People wear white coats, they use big words, they hold stethoscopes.
That's true. It is intimidating.
Patients frequently experience a psychological phenomenon where a doctor's recommendation feels like a mandatory order. If a patient doesn't actively realize they can say no without being punished or denied future care, their yes isn't legally valid.
Which brings us to the fourth pillar, and really the absolute core of our discussion today. Acting voluntarily, free from undue pressure.
Yeah, this is where the rubber meets the road.
How does a doctor practically separate a highly supportive, loving partner who has just done a ton of research and is overly enthusiastic from a coercive partner? Like, if someone is vigorously arguing for a certain treatment for me, how do you measure undue pressure?
It is the hardest tightrope a clinician has to walk. The service standards for sexual and reproductive health care explicitly warn health professionals to be on high alert for pressure from partners or family.
Because it invalidates the consent.
Exactly. Any form of coercion invalidates your consent. If you say yes to a procedure just to appease the person sitting next to you so you don't have to argue with them on the car ride home, that is not a valid legal consent.
But practically, how do they test that? They can't just kick the partner out of the room because they are being annoying.
Actually, the guidelines recommend a very specific safety checkpoint for this exact scenario. Yes. Clinicians are advised to actively engineer a situation to see the patient on their own for at least a portion of the visit.
Engineer situation, like a distraction.
Essentially, yeah. They might say, I need to take the patient down the hall for a quick x-ray, or we need a urine sample, follow me to the lab.
Oh, that's smart.
The whole goal is to get you away from the gaze and influence of your partner so they can ask, is this decision truly what you want?
I see the logic, but it fundamentally shifts how we view a routine checkup. We usually think of a doctor treating a bodily ailment, fixing a knee, prescribing antibiotics.
Right.
But here, the healthcare provider is essentially acting as a detective for human rights within a private relationship.
It is a profound responsibility, and it goes much deeper than just dealing with a bossy spouse. That safety checkpoint of separating the patient is a critical, life-saving tool for detecting hidden, dangerous forms of relationship abuse. Yeah, this is where the medical guidelines intersect with trauma-informed care guides from organizations like Futures Without Violence and the American College of Obstetricians and Gynecologists, or ACOG.
Because what starts as influence can very quickly cross the line into control.
Exactly. ACOG guidelines force doctors to reframe how they look at intimate partner violence. We often categorize IPV as isolated incidents of physical harm, like a black eye, a bruise.
Right, the obvious signs.
But clinically, IPV is defined as a repetitive pattern of behavior aimed entirely at maintaining power and control over another human being. And one of the most insidious hidden aspects of that control is a concept known as reproductive and sexual coercion.
Someone else literally trying to hijack your biology.
Yeah.
I can't even imagine the psychological toll of that. What does reproductive coercion actually look like behind closed doors?
It takes forms that doctors specifically have to screen for. It can be birth control sabotage.
What does that entail?
That means a partner intentionally throwing away your contraceptive pills, hiding your patches, or secretly poking holes in condoms.
Oh my God.
It can also involve severe emotional manipulation, threatening to leave you, or threatening to physically hurt you or your children if you don't agree to become pregnant.
And I imagine it goes the other way too, right?
It does. In some of the most extreme cases documented in the guidelines, it includes forcing a partner to carry a pregnancy to term against their wishes, or conversely, physically or emotionally, forcing a partner to terminate a pregnancy when they desperately want to keep it.
That is horrifying.
Yeah.
And because it involves intimate biology, it happens entirely in private. The victim probably isn't talking to their friends or coworkers about their birth control being sabotaged.
No, usually not.
That makes the doctor's office one of the only places in society where someone might actually spot what's happening.
And the medical community recognizes that they are often the only line of defense. This isn't just a criminal justice issue. Reproductive coercion profoundly degrades a person's health outcomes.
I'm sure.
It leads to higher rates of unintended pregnancies, maternal mortality, and severe mental health crises. The risk is so universally recognized that the Affordable Care Act actually mandates new health insurance plans to cover domestic violence screening as part of standard women's preventive services.
Framed as preventive health care, because stopping coercion prevents physical trauma down the line.
Exactly.
But let's walk through the mechanics of this. A doctor engineers that safety checkpoint. They get the patient alone. under the guise of taking a blood pressure reading, and they discover this coercion is happening.
Okay.
How does the clinic safely intervene? I mean, if they just hand the patient a pamphlet on domestic abuse and the partner finds it in the car, that could trigger a massive violent escalation.
That is the ultimate fear, and it's why the guidelines rely heavily on protocols called harm reduction. The goal isn't necessarily to fix the entire abusive relationship in a 10-minute visit. It's to reduce the immediate danger.
Okay.
For example, during an emergency contraception visit, getting the morning after pill providers are trained to use safety cards
But how does a card not trigger an escalation?
because they give them to everyone.
Oh.
The protocol is to educate all patients about relationship coercion, whether the patient has disclosed abuse or not. The provider says, because relationship violence is so common, I give this information to all my patients.
Oh, that is brilliant. It provides total cover.
It really does.
Like, if the controlling partner finds the card in a purse later and demands to know why they have it, the patient can honestly say, they literally hand it to every single person with the checkout paperwork. It removes the stigma and dramatically lowers the danger.
Exactly. Another fascinating harm reduction tactic detailed in the sources addresses how abusive partners monitor their victims.
Right, digital tracking.
Yeah, abusers very often track cell phone locations, text messages, and call logs. So simply giving a patient a hotline number isn't enough. Dialing that number from their personal device could put them in extreme danger.
So what does the clinic do?
They execute what is called a supported referral. Clinics are advised to offer patients the use of a private landline clinic phone to make the call right then and there.
Oh, wow.
They can contact a domestic violence shelter, formulate an exit plan, or speak to an advocate, and there will be absolutely no trace of that call on the patient's personal device when they walk back into the waiting room.
That is like life-saving spycraft, sliding an untraceable phone across a desk to give someone a lifeline.
It is.
But it's also a stark, depressing reminder of our main topic. True consent requires total safety. If you are afraid of the person you go home with, you cannot give legally valid consent to your medical treatment.
The absence of fear is a prerequisite for consent, but we need to look at one more angle here because the sources are very clear that coercion doesn't only come from intimate partner.
Wait, where else would it come from?
From the person wearing the stethoscope.
Provider coercion. You mean the doctor themselves pressuring the patient?
Yes. The ethical frameworks we are looking at point out that paternalism casts a long shadow. Provider coercion happens when a doctor, based on their own internal beliefs of what they think is best, crosses the line from recommending a treatment to compelling a patient through authority.
Let me use an analogy to see if I grasp the boundary here.
Go for it.
It sounds like the doctor is supposed to be a GPS navigator. They can look at the map, warn you there's a massive traffic jam or cliff ahead, and strongly suggest a reroute.
Right.
But provider coercion would be the GPS literally reaching over and yanking the steering wheel out of your hands.
That is a perfect visualization. The doctor can guide, but they cannot force. Provider coercion often looks like a doctor magnifying or exaggerating the risks of an option the patient prefers just to dissuade them.
Oh, I've heard of that happening.
It can look like threatening to withdraw care entirely, saying, if you don't do the surgery, don't bother coming back to my clinic.
That's intense.
In obstetric settings, it has even looked like a doctor asserting a woman is a bad mother or threatening to call child protection services if she refuses a recommended procedure like a cesarean section.
That is incredibly heavy. So the undue pressure in validating your consent could literally be coming from the person who is supposed to be healing you.
Which is why true shared decision-making requires the clinician to explicitly declare what the guidelines call the locus of control.
The locus of control, meaning they have to vocally establish who is actually in charge of the body in the room.
Precisely. One of the most powerful things a doctor can do to eliminate provider coercion is to look you in the eye and say, my duty is to ensure you are fully informed of the risks, but I will respect your ultimate decision and continue to care for you without prejudice, even if you entirely decline my recommendation.
Wow.
It places the locus of control unambiguously in your hands.
So what does this all mean for you, the listener, the next time you find yourself sitting on that creakly exam table? We started by asking if a partner's opinion should influence your treatment decisions.
And we found our answer.
Yeah. Legally, ethically, and practically, the answer is that consent is a solo act. While shared decision-making relies on a dynamic dialogue between you and your healthcare provider, a partner's opinion has zero legal standing unless you freely, safely choose to adopt it. Your body, your choice, your signature.
And that choice is shielded by layers of ethical guidelines designed to ensure your voice is the only one that counts. From the Montgomery ruling that mandates you are told the risks that matter to you, to the harm reduction strategies that screen for intimate partner violence, the entire framework of modern medicine is built to protect your autonomy.
But I want to leave you with one final lingering thought to mull over. We've established that for medical consent to be legally valid, you must be entirely free from outside pressure, duress, or coercion. But think about the digital world we live in today.
Oh, yeah.
Between algorithmically targeted pharmaceutical ads popping up on your social media, wellness influencers peddling unregulated health advice on video feeds, and the endless stream of aggressive opinions in your family WhatsApp groups, is ANY medical decision we make today truly 100% free from undue influence? When you sit in that exam room, how many invisible passengers did you bring with you?